Hi everybody, and welcome to our module on adolescent medicine. Let's start by talking about puberty. Puberty is broken down into a number of events which can occur at different times as the child grows. Thelarchy refers to the development of breasts. This happens when the levels of estrogens like estradiol increase in the plasma and have action on breast tissue. Menarche is the first menstrual period, and spermarchy is the beginning of sperm production in the male, and it's often followed by a nocturnal emission for the first time. And then finally, pubarchy is the development of pubic hair, and the main driver of pubic hair growth in both males and females is androgens. Many of these come from the adrenal gland in women. They also come from the testes in men, and that's what leads to the growth of pubic hair. The age of onset of puberty varies from person to person. It's also a little bit different between girls and boys. Girls usually start puberty a little bit earlier, anywhere from 8 to 13 years of age. They usually have menarche, the first menstrual period, somewhere around 12 or 13 years old. Boys usually start puberty between 10 and 15 years of age, and they usually have their first ejaculations somewhere around 13 to 14 years old. And then finally, there's a growth spurt of puberty where boys and girls become taller and their arms and legs become longer. In girls, this usually occurs earlier at about 12 years of age. In boys, it occurs around 14. Let's talk about the Tanner stages. The Tanner stages are the way we describe the stage of puberty of the adolescent as they move from pre-puberty to full adult sex characteristics. The Tanner stages assign a stage number to pubertal development that ranges from 1 to 5, and there are separate stages for development of male genitalia, female breasts, and pubic hair in both males and females. I'll talk about what the specific Tanner stages are for each of these elements in a minute, but in general, stage 1 is always the prepubertal stage, and stage 5 is always adult sexual characteristics. And stage 5 for all of these items here usually occurs by age 15 in males and females. Shown on this slide are the Tanner stages for males. So as I just said, stage 1 is always the prepubertal stage. In stage 2 in males, the testes begin to grow slightly and there is very sparse pubic hair present. In stage 3, the testes continue to enlarge, there's more pubic hair, and in stage 3, that's when the penis begins to get longer. In stage 4, the penis continues to grow in size, and this is when dark, coarse pubic hair begins to be present. And then finally, in stage 5, there are adult-sized testicles and penis, and there's dark, coarse pubic hair that can extend all the way to the medial portion of the thigh out here. The Tanner stages for females are shown on this slide. Once again, stage 1 is before puberty has begun. In stage 2, there's a very slight elevation of the nipples and the breast tissue. This is called development of breast buds, and sparse pubic hair begins to appear. In stage 3, there's further growth of the breast and the breast papilla, and there's darker pubic hair that begins to grow along the labia as shown here. In stage 4, the breasts begin to project out from the chest. This is called development of a secondary mound, because there's growth of breast tissue around the nipple and then also below that level. The pubic hair in stage 4 becomes coarse and curly and covers the symphysis pubis. And then finally, stage 5 is adult breasts and adult pubic hair that once again, just like in males, can extend all the way out to the medial portions of the thigh. Precocious puberty is puberty that occurs at an early age, which is usually defined as earlier than 8 to 9 years old in a boy or a girl. When precocious puberty happens in a boy, it means there is some source of excess androgens in the body. When it happens in a girl, it means there's some source of excess estrogens. And the one cause you always want to remember in terms of precocious puberty for boys is congenital adrenal hyperplasia. I talk about this under endocrinology, but the most common form of congenital adrenal hyperplasia involves production of excess androgens, and in boys the way this often presents is as precocious puberty. At the other end of the spectrum, delayed puberty is when there's no evidence of puberty by ages 12 to 14 years. And the most common reason this happens is called constitutional delay of growth in puberty. Basically, this is a benign form of delayed puberty that the child will eventually outgrow. For reasons that are poorly understood, some adolescents have a transient defect in GnRH release from the hypothalamus, and because of this, puberty starts at a later age, but then eventually progresses normally. This often runs in families, so a child who has delayed onset of puberty will tell you that their mother or father also had delayed onset of puberty. Besides constitutional delay, you can also have delayed puberty if there's underproduction of androgens or estrogens from some cause of hypogonadism. The most common cause of congenital hypogonadism in girls is Turner syndrome, and in boys it's Klinefelter syndrome. And then lastly, in terms of board exams, what you always want to think about when there's delayed puberty is Kallmann syndrome. This is a rare syndrome of GnRH deficiency that is also associated with loss of smell or anosmia. A child who is not entering puberty and has loss of smell, this is likely the diagnosis. There are a number of important things that need to be screened for in adolescence, and the way most people remember what you're supposed to screen for is by using what's known as the HEADS interview instrument. This is an interview instrument designed by the American Academy of Pediatrics for screening adolescents, and each letter in the word HEADS stands for one of the items that you're supposed to screen for. H is for home. This refers to asking the child if they feel safe at home and have a safe and good relationship with their parents. E is for education. This refers to asking about how the child is doing in school and make sure that they are going to school. The A is for activities. You want to ask what kind of activities the child likes to do and encourage them to engage in safe activities. The D is screening for drug use. The S is asking about sexual habits, encouraging children to abstain from sex until late adolescence or young adulthood. You also want to make sure the child has someone they can talk to about sex if they have questions. The S is screening for suicidality and depression, and the final S is for safety. This refers to asking if the child wears seat belts and if they have nonviolent ways of resolving conflicts that arise in their life. When it comes to screening adolescents for drug and alcohol use, annual screening is recommended starting at age 11, and the tool that's often used to screen adolescents for drug and alcohol use is called the CRAFT screen. The CRAFT screen is shown on this slide. It was developed by the American Academy of Pediatrics. The letters in the word CRAFT stand for the elements of the screening tool. So C is for car, which refers to asking the adolescent, have you ever ridden in a car driven by someone using alcohol and drugs? The R is for relax. Do you ever use alcohol and drugs to relax? And the A is for alone. Do you ever use alcohol or drugs while alone? The first F is for forget. Do you ever forget things you did while using alcohol or drugs? And the second F is for friends. This refers to asking them if family or friends tell them they should cut down on drinking or drug use. And then the T is for trouble. Have you ever gotten into trouble while using alcohol or drugs? A positive answer to any of these questions is a point, and if the child scores 2 or more, then they have a high risk of adverse outcomes, and they should be investigated further for problems around substance or alcohol use disorders. Confidentiality is essential to providing care to adolescents. They have to feel that whatever they tell their pediatrician, it will be kept confidential, because they may tell their pediatrician things about drug use or sex, things that they don't want their parents or teachers to know about. The only times you can break confidentiality when caring for an adolescent is if there is sexual or physical abuse, or if the adolescent reports suicidal or homicidal thoughts. It's very high yield to remember these things. If the child tells you about one of these things, you can break confidentiality and tell other people in order to keep the child safe. Let's talk about consent for care in adolescents and minors. So a minor is usually defined as a person under 18 years of age. And in general, in the United States, only a parent or legal guardian can give consent for a minor. The minor cannot give their own consent. There are 3 exceptions to this general rule. One is emergencies, the other is emancipated minors, and the last one is special situations. And we'll go through each of these 3 things in the next few slides. So for minors, when you're administering emergency care, consent is not required, it's implied, and you can administer care even if the parent is not present. You can even administer care against the parent's wishes. So the classic example, this often comes up on boards, is parents who are Jehovah's Witnesses and they don't want the child administered blood products. You can give blood products to a child against their parents' wishes if it is an emergency and the child is about to die. You do not need a court order. And the idea here is that the law wants you to be able to save the child's life in the setting of emergency and not have to worry about consent or parental approval or anything like that. Once the child is stabilized, then you can sort those other things out. An emancipated minor is a minor that has attained legal adulthood before age 18. There are different criteria for this, but some of the most common criteria include a minor who is married, who is in the military, or who has been living separately from their parents, managing their own affairs. These are considered situations where the minor is emancipated, and in that case, they can give their own consent. They don't have to have parental consent. So for example, in the military, if a recruit is 17 years old, you don't have to call that recruit's parents in order to deliver medical care. That is an emancipated minor. There are a couple of special situations you need to know about where minors can give consent and you don't have to get consent from the parents. Most U.S. states allow minors to consent only for certain interventions, and they can do this without parental consent. One of these is contraceptives. In most U.S. states, minors can receive contraceptive care. They can agree to it. You don't have to get the parents' permission. Another one is prenatal care. If a minor becomes pregnant, they can receive prenatal care in most U.S. states without having to notify the parents. The same is true for treating STDs in a minor or treating substance abuse in a minor. And the idea here is that if you required consent from the parents for all these things, many adolescents would not come forward to receive care in these areas, and that would lead to bad outcomes. So in most U.S. states, they've made the law such that minors can receive care in these areas without having to get approval from their parents. I'll finish with one slide on abortion. The rules on parental notification for minors regarding abortion vary by state in the U.S. It's unlikely this will come up on your board exams because the rules are very different from state to state. Some states require parental notification and even a waiting period before an abortion. Other states allow minors to consent without notifying their parents as long as they have been appropriately counseled. So once again, in actual practice, you want to know the rules for your particular state, and on your board exams, this is unlikely to come up because the rules vary so much across the U.S. And that concludes our module on adolescent medicine.